So, hi, I'm Dr. Nicola Ducharme. If any of you do not know me, I am the owner and medical director of Restore Medicine, an integrative medicine clinic in San Diego, California. And I've been working with Lyme for coming up on 20 years now. I've been in practice 20 years this year. And so recently went to Boston for the ILADS conference. And I have to admit, it's been a little minute since I've been to an ILADS conference. So I thought I'd just give you a few snippets and things that I heard that I thought might be interesting to share. I'm going to keep this super informal. I don't have slides or anything like that. What I did do, though, if I can just figure out my tech, what I did do is I have some notes that I can share with you so you can open them and follow along. And I'm really just going to sort of walk through them and where is that on? Talk through them. There's a few topics that are just like little snippets that I got, but anyway, I hope this is helpful to you. So I'm going to put this document in the chat. The other document I'm going to put in the chat is Dr. Horowitz's double dose dapsone protocol, because that's what he presented on, and I'm going to give you a little update on that. And the entire protocol is printed in a journal article, like including the supplements to go with it, what brand of supplements, what everything. So I have not put all of that in my notes. I've just put a few highlights that I kind of want to give you, but I wanted to provide that document so that you guys can look at that, print that out, have a read through, etc., etc. So do they appear okay to everyone? My only concern with putting things in chat is I think if people come on after, I don't know that they can always see it. But just keep me posted. I'll be looking at the chat a little bit as well. So keep me posted if that's working. If not, I can always open the document on my computer and share my screen, which might not be a bad idea either. Well, look, maybe I'll do that. Hold on. Take me a minute to get myself organized here, but that may be more helpful for you guys. Webinar notes. Here we go. And then, yeah, the journal article will just be in the chat. And if anyone needs me to email it afterwards or whatever, I can. So let's do this. And that way you can all for sure see it. And that way you don't have to just look at me. Is that right? Yep. Got it. Okay, except now I'm not seeing the chat. So anyway, we'll go like this. So one of the topics that was discussed, obviously Dr. Horowitz presented on this, well, not obviously, but Dr. Horowitz presented on this, is his double dose dapsone protocol. And so I wanted to just kind of give you an overview of how he put that protocol together, or kind of like the purpose of it, and then give an update on what he is doing now, because his protocol has like morphed and evolved somewhat. And so it might be sort of good to talk through that. So the problem that he's trying to solve is that the persister cells of Borrelia and Bartonella. So Borrelia and Bartonella are known to sort of create these persister cells, and other pathogens do that too. Mycoplasma, tularemia, brucella are some that he cited. But the persister cells are what make these pathogens and these infections so stubborn, right? And so hard to overcome. And so persisters can be round bodies or L forms. So they can look like different forms of the bacteria, or biofilm-like aggregates. So what we're going to see, and what he explained, is that these persisters are closely tied to biofilm. So that's kind of what he means by that, or what we mean by that. So the persisters can revert back into active motile forms, like growing bacteria in favorable environments. As persisters, they're kind of more like a dormant subset of cells. And we do know that the persisters tend to be pretty drug resistant, pretty antibiotic resistant, which is why, why he has been looking for this protocol and developing this protocol to kind of overcome that situation. So drugs that are effective against persisters. So dapsone, obviously this is like a key foundation of this protocol. Dapsone is also effective against biofilm. So, sorry, let me just stretch that piece, that biofilms play a large role for persisters, providing housing and a shield. So we know that biofilm exists for lots of different pathogens. I mean, Borrelia, Candida can create biofilms. We have biofilms in our mouth. There's lots of different biofilms that exist. But biofilms are like a hidey spot for these persister cells, and they will protect them. It's like, these things are like surrounded by this sticky goo that, antibiotics and other things can't get to. So that's why addressing biofilm is so important. So drugs that are found to be effective against these stubborn cells or these persister cells, dapsone, which also can be effective in breaking down biofilm. It has anti-malarial properties, so potentially helpful for babesia. It can be anti-inflammatory. It has good central nervous system penetration. It can reduce autoimmunity. But to note, it is a sulfone, so it's still in the sulfur drug category. So people with true sulfur drug allergies may not be able to take dapsone. It's also not without its side effects, which we'll talk about. Rifampin has been found to be effective against persisters, and it's also effective against actively growing bacteria. So that's why it's like central in this protocol. Pyrazinamide, he talks about as, being something used in tuberculosis treatment and the ability to shorten the course of the treatment. Yet it's not a medication that I've really sort of seen much about, and it hasn't really shown up as centrally in the actual protocol itself, but he does talk about it. Methylene blue, which was talked about a lot, well, a relative amount at ILADS. It seems to be like, a new kid on the block that's getting a lot of attention. And Thomas Moorcroft talked about that as well. But that is used as a persister drug for Bartonella and Borrelia. But one of its central roles in the dapsone protocol is to reduce some of the side effects of dapsone itself. And then macrolides. Macrolides, azithromycin is a macrolide. Clarithromycin is a macrolide. So they're meds that are commonly used in Lyme protocols and Bartonella protocols. And he likes to utilize them in the double dose dapsone protocol. They're lesser kind of specific for the persisters, but just good adjuncts, good in combination therapy. So previously, Dr. Horowitz reported that his double dose dapsone protocol, the 8-week protocol, was 45 to 55% effective in getting people into remission. And so what he has found in his studies is that the 4-drug therapy is more effective as opposed to the 3-drug therapy, which is more effective as opposed to a 2-drug therapy. So you can see these combinations here, and this is what he was using in some of his studies. So say if the 2-drug therapy had been minocycline and cefuroxime, for example. Well, they found that the 3-drug, being minocycline, cefuroxime, and azithromycin, or minocycline, cefuroxime, and rifampin, so those were more effective than just the 2, but at the same time, not as effective as with the dapsone in addition as the 4th drug. So that was reflected in the protocol from the beginning. So in the original double dose dapsone protocol, the dosing for dapsone was week 1, 25 milligrams, week 2, 50 milligrams, week 3, 75 milligrams, and week 4, 100 milligrams. And then weeks 5 to 8 were 100 milligrams, or is 100 milligrams twice daily. So the dapsone dose ramps up over the first month, and then in the second month, it holds steady at that higher dose. So say 100 milligrams per day is like regular dose dapsone. Therefore, 200 milligrams daily is considered then what they call double dose dapsone. So that's what he's achieving in the second month of the protocol. 400 milligrams is quadruple dose. But here's something I thought was really interesting. And that is that Dr. Horowitz said that in sensitive people, even the 25 milligram starting dose can have some effectiveness. Now, one of the things that I think is sort of that it's kind of like the elephant in the room. And I feel like a lot of practitioners at ILADS were sort of like, oh gosh, like when we hear about the double dose dapsone protocol, and I've put a few people through it, not too many, it's a lot and it's high doses and it's a lot of medication. And maybe I should have listed the protocol here just so you could see, but it's a lot. It's a very aggressive protocol and it's not without its risks and it's not without its side effects. And Dr. Horowitz is very confident. I mean, if he's done this with multitudes of people, he obviously has much more experience with how, you know, the outcomes and results and the side effects and what people go through. But he seems confident marching forward in the higher doses. So it was really interesting to me then to hear him say that, well, if people are really sensitive and just could not handle that protocol, we can still do smaller doses of dapsone and have it still be helpful. So that was a takeaway for me. And again, Dr. Horowitz is kind of at the forefront of this. So, you know, I'm trying to gauge in the ILADS community, and we do have an email listserv. So I'm trying to gauge from other doctors like who are using dapsone, but not necessarily at that massive, at the higher doses of the double dose dapsone protocol. But I think there's potential there to explore. Now, Dr. Horowitz might say, but look, if we're trying to get people into remission, like that, the studies that they've done show that this whole big thing is what's required. But if dapsone can help with the persisters of Borrelia and Bartonella, and, you know, a little bit maybe better than nothing at all, right? So that was interesting. Now, with the double dose dapsone protocol, methylene blue is a part of that. And so in the first month, it's 50 milligrams twice daily. In the second month, it's 100 milligrams twice daily. And again, I'm going to talk more about methylene blue in a minute, sort of in a different context. But they are still fairly significant doses of methylene blue. However, they are used not only to help with the persisters, but to help counter some of the side effects of dapsone. And I'll talk about that in just a tick. So what is new here that I heard at ILADS that I hadn't heard before? I'd heard about the double dose dapsone. I think that's been circulating. Dr. Horowitz has talked about that extensively. So what he is talking about now in his latest studies is a 9th week of a pulse of quadruple dose dapsone. So that's 400 milligrams daily, right? So remember I said standard sort of daily dapsone is 100 milligrams. Double dose dapsone is 200 milligrams. Now we're talking about 400 milligrams daily of dapsone and 300 milligrams twice daily of methylene blue. And he's doing that for 4 to 6 days as a 9th week of the protocol. So the 8-week protocol, which, and like I said, I really should have put this in just for the like visual, but so on this 8-week protocol, I mean, it's not just dapsone, methylene blue, rifampin, doxycycline, hydroxychloroquine or Plaquenil, and then, did I miss anything? Zithro or Clarithro. I mean, it's a lot. It's a lot of medication. And what he is saying is that, you know, we have people on long-term antibiotics. And I know that the majority of you are doing this, like in this journey as patients. So, but, you know, we do long-term antibiotics, which has its risks and its shortfalls as well. His point is maybe we can hit it harder but for shorter periods of time and get people off antibiotics. So, yes, it may be stressful on the body for that 8-week period or the 9-week period, but what if they could get into a point of near remission at that point and be able to not have to continue and do long-term antibiotics, right? So that's kind of one of his viewpoints that he expressed. So, I mean, in this 9th week, if it's like considered a pulse week, 4 to 6 days, 400 milligrams daily of dapsone, 300 twice daily of methylene blue, with the doxy and the rifampin, and he also does nystatin and other medications as well in the mix. Then he is talking about doing such pulse that 9th week, quadruple dose dapsone, high dose methylene blue with the doxy, the rifampin, the azithromycin, all the things, and doing a pulse every 6 to 8 weeks. And this is assuming that someone's not in remission at the end of the 8-week period, right? But remember, the rate of remission was like 45 to 55%. So there's going to be roughly half the cohort that may have improvement and maybe significant improvement, but isn't going to come through that 8-week protocol in remission. So he's then saying, let's do this massive dose pulse every 6 weeks or 8 weeks until we get the job done, right? Until remission is achieved. And he suggested the pulses being 4 days if there's no Babesia or Bartonella, but needs 6 days if there is Babesia or Bartonella, especially Bartonella. Okay. So Dr. Horowitz also said that the pulse schedule could be done even without doing the double dose dapsone protocol first, but he wouldn't know, he doesn't have the background knowledge on that to know how many pulses would be necessary. And he also did make the comment, and I mean, so my addition to this would be that awfully high doses be taking without building up, right? I mean, just jumping in at 400 a day of dapsone and 600 a day of methylene blue could knock somebody on their tush. And he made that comment also, like in the 8-week protocol, like not everything is started all at once, and people maybe put on the, doxy and rifampin first, and then add in hydroxychloroquine, and then add in the dapsone, so it can be a bit staggered. So to just go straight into like, okay, let's just dose this massive weekly 6-day thing every 6 to 8 weeks for somebody who hadn't had any lead up in terms of building into the meds and building into the doses of meds, I think could be really problematic. But he did say that it could potentially be done. He didn't say how much he's had experience with that. So then somebody asked the question, if we're dealing with mold as well, how do we factor all that in? Because by the time you're doing the double dose dapsone protocol, and I mean, there is a boatload of supplements that goes with that protocol, everything from all kinds of liver support, like multiple probiotics, antioxidants, high dose methylfolate, so much. It's a massive protocol. So if someone's doing all of that, like there's just no space for treating mold as well. So what he said with that was do the 9-week protocol, then start mold treatment. And then if you go back and do another pulse, say 6 weeks later, then you pause whatever you're doing for mold at that point. Right? So that if you go back and do another pulse of the high dose, the quadruple dose, then you just take a week's break or a 6-day break from the mold stuff that you're doing, and then kind of go back and toggle back and forth, if you will. So warnings, precautions, contraindications. The biggest thing is with dapsone and methylene blue is one must be tested for a G6PD. Or G6PD deficiency. It's an enzyme And if that level is off, then dapsone and methylene blue are absolutely contraindicated, right? It can cause hemolysis of the blood cells, and it's not to be messed with. So dapsone will cause drops in hemoglobin and methemoglobin. So it will cause an anemia and a methemoglobinemia. So that's a kind of, it's like a type of hemoglobin, right? So hemoglobin has to do with our red blood cells. And if, for example, say if you get iron deficiency anemia, it will usually show up as low hemoglobin and low hematocrit. And I know I'm using some medical terms here, so if some of this goes over your head, but it's at least you have this info so that if you are considering doing this, you know the things. Like some practitioners are starting to do some of these protocols and it's new to them, just as it's new to me and it's new to a lot of practitioners. So just double checking, like making sure that they're ordering these tests and whatever. It just means that you've got, you know, a little bit of knowledge to kind of come up with, firstly, to make sure that it's as safe as possible, but also, you know, that you've got as much knowledge as you can to make an empowered decision and an educated decision about whether this is a protocol that's worth taking on in your own healthcare. So we need high dose folate to try to counter the drop in hemoglobin related to folate loss. So in the protocol, there is leucovorin and there is high dose methylfolate. The methylene blue helps to counter the methemoglobinemia. Okay, so the methylene blue helps with the persisters. It's got some other, you know, valuable traits, but one of its big roles is to help to counter that methemoglobinemia. And that is why we see as the dapsone dose goes up, the methylene blue dose goes up, right? So it's there as a preventive to try to balance some of the side effects. Now, when asked on the side effects and the, you know, and the hemoglobin drops and the methemoglobin drops, Dr. Horowitz was like, yeah, it's going to happen. You're going to see it. We're testing every 2 weeks. But it corrects at the end of the protocol. And he seemed pretty darn confident about that. So, you know, I know as patients it's concerning, as a practitioner it's concerning. Like the people I've put through this protocol, I was like, oh, yikes, what's happening, what's happening? And actually Dr. Horowitz was kind enough to talk to me on the phone and I got some questions answered. But it can be, it's a little intimidating, I won't lie. Like even to, I mean, not even to me, because in some ways I treat aggressively with Lyme, but this is new stuff. This is new protocols and different medications and whole different set of side effects. So theoretically, you need to test both every 2 weeks, the hemoglobin, which is super easy to test, and the methemoglobin. But what I found personally, and Dr. Horowitz didn't speak to this, so he seems to not have any problem getting this test done, I could never get it run, like either through LabCorp nor Quest. And I had the test code from Dr. Horowitz, and they just didn't do it. So that was sort of a little bit challenging. I saw the hemoglobin levels going down, but I couldn't measure the methemoglobin. And surely enough, those levels did come up in my patients after the fact too, but I've got, like I said, compared to Dr. Horowitz, a tiny, 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 tiny pool compared to what he's worked with. So he did say levels typically correct post-protocol. But, you know, if you're somebody that runs low in hemoglobin to start with, that may be more of a caution about going into the protocol. So like I said, G6PD deficiency, absolutely not. Okay, so you must check the G6PD first. And that is an easy lab to get done. LabCorp, Quest, anyone can do that. That's also a test that should be run before doing high-dose vitamin C. That should be run before doing ozone therapy. So it's a test that we run for some other things as well. So what I'm going to do is I'm just going to stop my share and just kind of bounce in here. So yeah, Kathy's saying can't see the document. Let me just do some troubleshooting along the way so that you guys get the most out of this. Can someone post in the chat if or Kathy, maybe you can tell me, you can't see the document, you can't see my screen share, or you can't see the document posted in the chat? Nothing in the chat. Okay, so maybe it is, so I've got it to everyone. I can always circulate this afterwards on email, so don't panic. I'll make sure you can get the notes. But I'm going to put them in again, just in case, like if you came in after I posted them. It says it's sent successfully. Simon, thank you. All good on your end. Okay, so we'll just try because it may be. Oh, the test before ozone therapy is the G6PD deficiency. That's the test, the same test that should be done before taking methylene blue or Depsin. Okay, and let me just pop that protocol, that journal article with the protocol one more time. Again, I think when you come into a Zoom, you don't see the chat that's happened before you were there, is my understanding. So let's see if that says it that said it went through. So, all right. Maybe I'll post them one more time at the end, just in case somebody else didn't get them. But I'll keep sharing my screen so that if you haven't got it, you can at least follow along with what I'm talking about. All right, so that was sort of the big thing. Oh, what did I just do? Okay. So that was sort of the big topic, was the double dose dapsone. And then let's see what other snippets. So Dr. Mozzaiani, which I never feel like I can pronounce his name, he talked about Bartonella, like he is known as an expert on Bartonella. And okay, let me address this question. Vanessa's asking a question. Let me address this before I move on. And it was the $1 million question about, do you treat mold first and do more detox? Is it less likely you'll need to treat Lyme? So different practitioners have different viewpoints about what needs to be treated first. And I hear it both ways. Some people say, no, you've got to get rid of the Lyme, otherwise you can't clear the mold. Or my view is there are different situations where different things seem dominant, right? So like if I've got someone who, and I've had a couple of patients this week who clearly have tick-borne infections that are testing positive, but their real-time labs are showing mold level, mycotoxin levels of like 5 or 8, instead of like 0.12 or whatever it is. And so if there's like raging mold and someone is full of mold, then yes, you need to address that first. You need to make sure they're not living in mold, and then get those levels down just to sort of clear the space and clear some of the stress on the immune system. But if I've got someone that, yeah, they have some mycotoxins, but they also have pretty dominant, Lyme type infections, tick-borne infections, then I will honestly try to run them side by side. And there are things that we can do for mold illness. Like we always say mold, it's not mold, it's either mycotoxins or mold illness. There are things that we can do for that overlap with things that are helpful for tick-borne infections, like the detox support, like glutathione, like binders, like I use a lot of phosphatidylcholine for like membrane repair and ATP. So, there are things that we can kind of use that cover both bases. Now, obviously with tick-borne infections, we're going to need antimicrobials. And so that's sort of a separate thing. And there's obviously other binders and other things for mycotoxins that kind of go off as a fork in the road. So I'm not really a strict one thing or another first, but I know some practitioners are. Like Dr. Horowitz, I mean, he's a Lyme doc, and I'm not saying he's not knowledgeable about mold, but for him, he's looking at the Lyme, the tick-borne infections. He's like, right, how am I going to deal with this? try and knock that out of the way and then kind of deal with mold and whatever else. But I also know other practitioners who are like hardcore, like, no, if there's any mold, we're not, we're not going any further. Oh, look, I figured out how to get the chat and the Q&A and my screen share. I'm so clever. Okay, so what's the best test for mold in the body? Well, that's another good question. And maybe I need to like get through my little notes here, and then I can see if there's time for questions afterwards, or we could just stay here all night, either one. Because I'm happy to answer questions if I can. But the test I'm using, okay, so, all right, let me back up. Real-time labs, in my opinion, was kind of gold standard back in the day, but they were also like $900 for their mycotoxin test. Then Great Plains lab comes along, and Great Plains is now called Mosaic. Great Plains comes along with their urine mycotoxin test for $300. And all of a sudden, like for me, again, background as a Lyme doc, I've learned about mold out of necessity. I was then much more willing to ask more patients to do a mycotoxin test for $300 than $900. Now, yes, I'm still the one that's asking everyone to spend $1,600 on IGenics versus doing the Vibrant panel. And that's actually like my last point here. And I do want to touch on that because I'm very passionate about it. But, for something that to me back then, like 5-6 years ago, was still kind of like a secondary consideration, which is a little naive knowing what I know now. So that's what I was doing. Come to find out then, some of the docs that I really respect, Neil Nathan being one of them, was like, there's something about Great Plains or now Mosaic's methodology that he wasn't happy with. He's gone back to real-time labs, and real-time labs has also become more cost competitive in the market. So real-time labs kind of came back into the spotlight as like, maybe this is the best. I've got to be honest with you. I'm in a phase right now where I am suggesting people do both, the real-time labs and the Mosaic. And I'm sure that won't go on forever, but Mosaic seems better at finding ochratoxin and aflatoxin. But there are some things that real-time sort of is better for. And so right now I'm running parallels. Now, maybe I'll do that a dozen times and feel like I'm really clear on how I want to move forward. And I'm being very upfront with patients about like really explaining why, if I'm, and a lot of them, well, it's not been oodle so far, but some of them have said, look, no, I'm willing to pay for both tests. I want all the information. I want the best information. So that's kind of where I am right now. I'm leaning towards real time. If I can get a parallel on Mosaic at the same time, so I can compare, then that's ideal for right now. But down the road, I'll have an update because I won't run double tests forever. Okay, let's get back on track. And then if you have a question, pop it in the Q&A and I will get to as many as I can later. All right, so I'm going to call him Dr. M so I don't butcher his name because I can't pronounce his name. So there's not a lot of clinical information here. He was sort of talking mostly like research-based. One of the reasons I used to love, I've been going to ILADS conferences for like 18 years. And, then I had my daughter and then there was COVID and whatever. So there's been a bit of a lull, but sometimes there's a lot of like sort of research presentations. Like I'm always trying to get the clinical snippets, which is kind of what I've tried to pull out here was like, okay, here's the clinically relevant snippets. But some of the presentations were a little bit research heavy. So that's why if there's not like a ton here, that's why. Okay, so Bartonella. So he made the comment that Bartonella can be transmitted through cat scratches, which we knew. It's one of the strains is cat scratch disease or by any biting or stinging insect, right? So it's not just tick-borne, like we were finding out with a lot of these bugs. He is also finding that clarithromycin is more effective than azithromycin. So Zithro has been like a real staple of like azithromycin with rifampin, with methylene blue, like that's a really common lineup these days. But he is saying that he's finding Clarithro to be more effective than Zithro. And he made a couple of points that I didn't really know. He said Clarithro can also help with adrenal fatigue. And Zithro may activate mast cells where Clarithro may stabilize them. So I thought that was pretty interesting. He did talk about how rifampin induces several cytochromes, which is enzymes relating to part of the liver detox. And so it can lower hormone levels. So I try also with women who are taking the contraceptive pill to be a bit careful, because rifampin may mess with that. But we do know that rifampin interferes with a lot of drugs and can make some medications less effective. Mepron and Malarone are good examples. Rifampin reduces the efficacy of Mepron or Malarone, which are two drugs used commonly in babesia treatment. Sometimes we do them together anyway if we really have to. We have two dominant co-infections, but that's just an interaction. I tell my patients it's not a harmful interaction. But, Mepron and Malarone are also not inexpensive medications. If people are paying out of pocket for them, they may not be happy that rifampin's like knocking it down by 25%, but sometimes we do. So that's just to bear in mind. Said that rifabutin only induces one of those enzymes, but that clarithromycin might help to balance out that cytochrome P450 inhibition, right? Hence, if it did that, there'd be less impact on hormone balance, right? So what he was saying is, if rifampin influences enzymes that mess with hormones, if clarithromycin helps those enzymes, then it might mess less with hormones, right? I hope that makes sense. But he also made the comment with rifabutin that there are cases of uveitis, which is an eye condition, and potentially worst case scenario could lead to significant visual problems. And so he's using rifampin first. He's definitely a fan of rifampin over rifabutin and clarithromycin over azithromycin. So that's kind of the latest and greatest from Dr. M. The other thing about rifabutin that is concerning is it does lower white blood cell counts. So I have a patient that's on rifabutin right now. We had this conversation this morning. White cell counts down around 3. It's not getting any worse. We're sort of like, okay, well, this is going to happen. Like it's just, again, it's an education thing. It's like the dapsone thing. It's like what your tolerance is. For him, he's had good results with rifabutin, so he wants to stay the course. And I'm just kind of, watching and waiting with some concern, but also just not seeing things get any worse. In fact, stabilize a little bit in some markers. So kind of encouraging there. All right, so methylene blue. Lots of people talking about methylene blue. Some still not really using it, but kind of interested in it. But yeah, there were a couple of different presentations that talked about methylene blue. So looking at the functions then, so we've talked about this with Dr. Horowitz. It balances the methemoglobinemia that often happens with dapsone, especially over 100 milligrams a day, with primaquine, especially over 30 milligrams a day, and tafenoquine, especially over 300 milligrams daily. Now, I'll talk about tafenoquine in a minute. It's not dosed that high, but that's the numbers that were given. So it works as an electron shuttle. So it can help with mitochondrial repair. It can help with the production of ATP within the mitochondria, which ATP is our energy currency, right? So more ATP equals more energy. ATP is produced in the mitochondria. So if the mitochondria are damaged, whether through inflammation, through toxicity, whatever the case may be, then its ATP production is going to be compromised. So that's kind of one of the things, and people look to methylene blue for a boost in energy. It also helps to supply NAD, which again can be an energy, can help with energy, like brain clarity. And it is an antioxidant. It can become oxidative at very high doses, but not in doses that we would realistically give. They were giving, citing like 5 to 10 milligrams per kilo, which is, that's a lot. So it's cited as being a malaria drug and working like chloroquine. I haven't, So it's unknown. I mean, I haven't necessarily seen in my folks that I'm doing methylene blue with, I'm not necessarily noticing big changes in Babesia symptoms, but we'll see. It's not thought to be great on Babesia microti, and it's kind of unknown for Babesia duncani. So I think that's still a bit of a gray area. Best used in combination with zithro and rifampin. Dr. M would say with chlorithro and rifampin. So, you know, that will probably influence how I'm prescribing that for people as well. It's well absorbed in the GI tract, so it's good given orally. Good blood-brain barrier penetration, but it does have a short half-life, which is like it's how long it takes to kind of like expire in the body. So that's why we dose it twice daily. And then Dr. Moorcroft was saying this, and I agree. I mean, where possible, get methylene blue compounded, just because it's going to, you know, reduce contaminants that could be present in other sources of methylene blue. So I know that's tricky for people that, you know, may not have a prescribing doc, or their doc may not be willing to do it, or whatever the case may be. But anyway, that's my word of advice, is to get it compounded so you've got the purity and the quality control there to reduce contaminants. So cautions, contraindications here. G6PD, we've already talked about that. That's a big one. Contraindicated with many antidepressants like serotonin, SSRIs, those kind of things. It can cause an increase in serotonin, which if you're already on an SSRI, and that's sort of just boosting your levels of serotonin, then the methylene blue can just add too much to that, and serotonin syndrome is not a pretty thing. Do not use with amphetamines, and not for use in pregnancy. So here's my little addition on that is, we're 45 minutes in, I've only got to page 2 of 7. Okay, I'll keep moving. So my addition on that is I found that 25 to 50 milligrams twice daily was just too high for some people. It was really overstimulating. They weren't doing well on it. They couldn't stay on it. It just wasn't manageable. So I have started dosing even at 5 or 10 milligrams twice a day. And especially for more sensitive folks, I found that's a good starting point. PD Labs, who I used to use exclusively for methylene blue, were only doing the 25 milligram capsules. I'm pretty sure I talked to them at ILADS. I'm pretty sure I'm correct in saying they will now do 10 milligrams. I've also found a couple of local pharmacies that will make 5 or 10 milligram capsules. And I've put the names there in case it's helpful for anyone who may be in California. Carmel Valley actually will send out of state as well. Dr. Moorcroft said that methylene blue can improve memory extinction. So helping to have people unlearn the fear response. And it also improves memory, focus, arousal, things like that. It's good for brain fog. But the fear response was interesting because I know a lot of folks with Lyme like have a lot of PTSD, and they've got a lot of trauma and a lot of fear around their illness, around their treatment. So it's a really interesting potential if methylene blue can help those memories kind of go away and help people get out of the fear response. So I thought that was pretty cool. Okay, I'm just going to touch on this quickly. I just thought it was so awesome that this was at ILADS that I had to just put it in there. Dr. Kindelera talked about psilocybin and about microdosing and about the potential benefits for like anxiety, depression, PTSD. His PowerPoint was actually not in the folder that we could access later. So these are just a couple of notes I took during the talk. But if anyone's interested in this, he suggested a great book, and I'm actually listening to it on Audible right now, called How to Change Your Mind. And it's all about the history of psilocybin and I guess the psychotropic drugs, and how, you know, there was a lot of research done at one point, and it was a very, very promising therapeutic intervention. And then it kind of went off down the, you know, magic mushrooms and LSD, pop culture of the 60s and the 70s. And then, so it's really been restricted. And I mean, to be honest, these substances are class 1. They're not sort of legal substances if you ask the FDA. But there is a population of people out there using them and getting help from them. So he also talked about this this company psilocybin. He didn't say that he has used them as a source of these mushrooms, but he did throw it out there. I went to their website today, you know, for science, and it turned out that you can order, they'll give you, like, they'll send you a couple of like free complimentary trial packs of like 5 capsules or whatever, and you just pay the $7 shipping, whatever. So of course I ordered them, but you know, we'll see. Take that and do with it what you will. Oh, and Sandy's saying there's a series on Netflix called How to Change Your Mind. I wonder if episode 2 or 3 talks about psilocybin. So, so that might be cool too, looking up something on Netflix. All right, so moving on, there was a presentation about primaquine and tefenaquine, presented by 60 Degrees Pharma. So this was a sponsored lunch. This was a company kind of presenting on their drugs. But they are medications that we're definitely hearing a bit about now in treatment for babesia. So I just wanted to touch on some basics here. Now, these meds can also cause this methemoglobinemia, right? So here we go with the methylene blue again. But again, must have G6PD tested first. The primaquine, they cited, and the research on these drugs is on malaria, right? So the application of these meds for use in babesia is still kind of unknown, right? I mean, there's theories about it, and I know some docs are starting to use this. I've got a couple of patients on tefenaquine, but I also had a patient who was given tefenaquine by her prescribing doc and had a massive, massive crash that set her back a lot. So again, with these new drugs and new protocols or new applications of the drugs to our tick-borne illnesses, you know, we have to go in just kind of cautiously, I think, because there's still so much unknown. So it's that tough spot between, like, we want to try new things because everyone's sick of, you know, this dragging on for ages, and everyone wants to get better quicker, and I want my folks to get better and back enjoying their lives and all of the things. But we also have to be kind of, you know, sensible about it and cautious about it. So they said that the primaquine was not predicted to be as effective for babesia, and that tefenaquine was considered having a greater efficacy, and a greater potential for babesia treatment. So they were talking about doing a loading dose of tefenaquine, which is 200 milligrams times 3 days, so a total of 600 milligrams. And then one of the studies cited 300 milligrams per week for up to 6 months, and a couple of other ones cited 200 milligrams. So that's kind of the range, 200 to 300 milligrams per week for up to 6 months. It needs to be taken with food just to offset GI side effects. And Marty Ross talks about these meds. And Marty Ross is a really smart guy. He was talking about 300 milligrams every 1 to 2 weeks. So the first patient I started on tefenaquine, I started on 100 milligrams because I was chicken. And they tolerated that fine and are building up the dose, but that's kind of the dose that they're talking about. Dr. Marty Ross doesn't necessarily talking about a loading dose from what I can see in his material, but that 200 to 300 milligrams every week or so seems to be the sweet spot. Primaquine, the dose given was 30 milligrams daily in the presentation. Marty Ross cites 26.3 milligrams and 2 pills daily as his standard dose. But you can see here with the half-life, the primaquine half-life is short and the tefenaquine half-life is long, like 17 days, which is why it's not given daily, it's spaced out more. But, you know, bear in mind then that if you take tefenaquine and don't do well with it, it's going to be in your system for a good long while. So I think it's, you know, I think it's always wise to start smaller. I will say I dosed a lot of Lariam back in the day, which was mefloquine. And that was given like a few days in a row and then every 5 days. And I liked it. Lariam got really bad publicity because they did some studies in military, and there were some episodes of psychosis after the dosing of Lariam. But I'm sort of like, okay, these are military people who just come back from like war zones and probably have massive PTSD. And you know, is it all about the meds or is it about like the experience of what they've just been through, you know? So I don't know. I saw some psycho-emotional stirring up of symptoms with Lariam or mefloquine. But, you know, I couldn't have been sure it wasn't a Babesia Herx too, because these meds do get to the, you know, central nervous system better than some of the other, like the Meprons and the Malarones that we've been using forever. So cautions here: oxidative stress, G6PD deficiency. I think I've honed that one in. The methemoglobinemia, and possible neutropenia, which is a low white blood cell count. And most of our patients are having their white cells monitored anyway. And chronic Lyme folks tend to run low to start with. So that's something just to be really cautious of. You don't want to wipe out your white blood cells so you've got no immune protection left. Side effects of these drugs: cornea verticillate, I don't even know how to pronounce that, which is an eye pigmentation. It's not something I've ever really heard of before. Visible by an ophthalmologist, reversible at end of treatment, and no effect on functional vision. Some GI upset, hence take with food. Methemoglobinemia, you're going to be sick of that word. Hemolytic anemia, which is where the blood cells can actually hemolyze or break down. If there's a G6PD deficiency, right? Hence checking for that. Some psychiatric events in untreated severe mental illness. So if there's really severe mental illness that's unstable, then this may not be a good idea. Increases in creatinine, which resolves within 12 weeks of the treatment period. Some drug interactions, metformin. They didn't really explain the mechanism of that, but since metformin's common, I thought I'd just pop it on there. And then potentially dizziness, headache, that seemed to be a less common side effect. At higher doses just seem to produce more GI distress, not necessarily anything else. So take homes on that: G6PD, yes. Methylene blue, yes. Tefenoquine, more effective than Primaquine. But also, I mean, these are not cited as like standalone meds. We're still using these, or they're still proposing using these in conjunction with like Zithro, Doxy, Atovaquone, Mepron, Malarone, those kinds of things. Okay, so I thought I would also just share a little bit about exhibitors. Like, I love going to conferences and just chatting to the exhibitors and seeing kind of what's going on out there. So the first one here is a company called MolPros. Now, let's be clear, when exhibitors are at conferences, they're there to promote their own business, right? So these are companies, some I'm familiar with, some I'm not. I will share which ones I am and which ones I'm not. But the MolPros is a company that I just met for the first time. They are a national company, so they have reps all over the place, and they offer a variety of in-home testing options, seemingly at a reasonable price. Like, they did, you know, I talked to them about like the types of tests that they're doing, and how they're doing their testing. This is of homes, not of people. And, you know, their whole list of sort of different things that they do was sort of like in the $1,600 range, whereas I've sort of heard of that more in the $4,000 or $5,000 range before. So I'm going to do a webinar with them. So stay tuned, because I feel like for me, it's always tough to know. Like, I know there's people with more experience, and you know, Scott Forsgren's on right now, and I know, Scott, you know a ton about this, and I just feel like I'm sort of still in catch-up mode about like dealing with the actual house. What are the testing options? What's better? What's more comprehensive? What's less comprehensive? Like, asking those hard questions about what has to be thrown out. Is it porous stuff? Is it non-porous stuff? Do we need to move? Do we need to, you know, like, they're hard questions. So, you know, I'm going to do a webinar with them again. Like I said, full disclosure, they're going to be, you know, they're promoting their company, but I feel like the people I talked to there were really good, solid, nice people. They seem to know what they're doing. I think any information and education there is helpful. So stay tuned for that. I'll put that out on my email list or social media or whatever. Now, BrainTap is another one. So I have known about BrainTap and used BrainTap for some years. Full disclosure, I have been an affiliate for BrainTap as well. It's a technology developed by Patrick Porter. And it actually sort of came about like after, you know, these platforms of Android and Apple and these smart devices and us being able to do so much on these sort of portable devices that he wanted to get in and help people with neuroplasticity and like brain health, brain fitness. And so the brain tap is, it's two parts. One part is the programs, the track, like the software kind of part. It's an app that one gets, and there are sessions that you access through the app. The second part is headphones with glasses for then sort of better sound and also light therapy. And they were doing demos at the conference and they were busy. Everyone wanted to try it. It was great. So it's a blend of spoken word, sounds like binaural beats, different tones, 10-cycle holographic music, and light therapy. So it all goes together in a way to support neuroplasticity and brainwave training. So again, we're training the brain, we're teaching the brain how to go from these like high beta frequencies to down into more like the relaxed state of alpha. And then theta is sort of even deeper relaxed than that. So it's helping people get out of the sympathetic fight or flight response. And there's all kinds of different tracks. There's like wake up tracks for alertness, there's sleep support tracks, there's all kinds of different things. So if you're feeling stressed and anxious, you know, you can choose, like there's multiple categories of tracks to choose from. So one can just get like a subscription on the app and just access their tracks and use with your own headset on a compatible device. So you can do that. The Brain Tap headset is neat in that it also incorporates the light therapy, which has an impact on those brainwave patterns and brainwave frequencies as well. Benefits are improved sleep, improved cognition and memory, reduced levels of anxious feelings and stress, increased parasympathetic response, which is less fight or flight. And we know that the sympathetic or the fight or flight response, like healing does not happen in the sympathetic mode, right? If you're in fight, flight, or freeze, you're in survival mode. And so the parasympathetic or the rest and digest is where your body can really heal. But we get so stuck, I mean, through life and circumstances and stress levels, but also people with chronic illness, like it's just, unfortunately, part of what happens to the brain is it just gets stuck in this fight or flight response. And so Brain Tap is a nice way to kind of help balance that out. And, you know, certainly, and Heather, thank you for your comment, and Yoga Nidra has been helpful. There's certainly different ways, and thank you for sharing that, because it's great to have all the tools. Headspace is another one. There are definitely different technologies, different apps, different places out there. Brain Tap's just one that I have been in contact with a lot of years. And I think it was actually Scott Forsgren that connected me with Brain Tap in the first place. But I know I got a lot of benefit from it myself. You can get a 14-day free trial if you want to try it. There's a link there. I'll put the link in the chat as well. But so they were there, and that was pretty cool. They were really popular. Another thing that was there was this oro-glutathione spray called Glutaril, and it's a topical glutathione. And another colleague had talked to me about this before and thought it was pretty cool. I have looked for topical glutathiones before, frankly, because every night, as I'm putting my daughter to bed, I like rub cream on her back, and I'm like, oh, this would be cool if I was like actually rubbing glutathione cream or something. But everything I found was really like grainy and kind of gross. So I was like, okay, this is interesting. I'll look at it. So the Glutaril is the sort of standard maintenance kind of 100 milligrams per ml, and the Glutaril Plus, they say, like for detoxing and post-viral support. Frankly, most glutathione, like all glutathione, so long as it's well absorbed, is going to be helpful for detox. I wonder if the post-viral support is just in the age of COVID, you know, that's a good thing to say, but that's the stronger one. It's 200 milligrams per ml. They say like 2 to 8 pumps or sprays daily applied to the stomach area, and make sure to leave on the skin for at least 30 minutes. It's a tiny bit sticky. I mean, I tried it. It's a little sticky. And suggested using it twice a day because glutathione also has a short half-life. My question was always absorption. Their absorption studies seemed valid. So I think this could be good for people that either cannot tolerate glutathione orally, they can't stand the taste of it, it makes them nauseous, whatever. And it may be a good option for kids as well. However, it's expensive. So the standard strength bottle is $120, and then the Glutarol Plus is $200. So bloody expensive. And I think at standard dosing, that was like a month supply, maybe 6 weeks, but not really beyond that. But I thought it was interesting they were talking about the half-life of glutathione, because, you know, some people go and get an IV once a week with glutathione, and it's not going to last all that long. So that's why I actually have people dose, and I like the liposomal glutathione. I tend to use the Research Nutritionals, the Trifortify. But even if people are getting IV glutathione, I like them doing the liposomal on other days, just to keep the top up, just because glutathione doesn't kind of last in the body for super long periods of time. All right, let's see. Okay, leaving the best for last. Okay, so Vibrant versus IGeneX. And I'm just going to be really honest. I have an issue with Vibrant testing for Lyme. I'm not saying I'm not for any of their other testing. I think their total tox panel or whatever it was is decent. I don't use them for mycotoxin testing, but I have a lot of patients that come to me from other practitioners who have done Vibrant testing. And yes, at face value, it's a lot cheaper than IGeneX. However, here's my issue with it. So Vibrant rates the results, like the antibody response, which is what we're measuring, to a certain pathogen, right? So antibody testing may be IgM, it may be IgG. There's kinds of different antibodies that they can test response to a certain pathogen or a certain strain of a pathogen. So Vibrant classifies it this way. 0 to 10 is considered low, or what I would say, if we're looking for, is this a positive or a negative diagnosis? I would say that that would be then negative. 11 to 20, they consider moderate. So if it's not sort of nothing, but it's not high and it's moderate, then I would sort of, in my language, that converts like indeterminate, like not quite yes, not quite no, somewhere in the middle. And then 20 or above, or 21 and above, is high. So we consider that positive. So they look at it as low, moderate, high. Probably IGeneX language, or how I would interpret that as a practitioner, is like negative, indeterminate, positive. My issue is that if they're looking at a certain strain of a certain pathogen, and that antibody result is 11.2, for example, it will show up on the positive findings summary on the first page. So on their report, which is like 57 pages long, they have the first page, which shows all the strains and whether they were IgG or IgM, and that's all. It has, so list IgG, IgM, and the strains that show up on the positive reporting. My issue is that strain with 11.2 is going to be on that page. And I hope I'm explaining this clearly, because I know it gets a little convoluted. On the page where they have the Western blot, so in general terms, think that a Western blot, you need certain bands to be positive, right? So if a certain band on IGeneX is indeterminate, it doesn't contribute towards the total result. Right, so let me say that again. On IGeneX, say on the IgM Western blot, for example, you need 2 bands to be positive to get a positive result. If 1 band is positive and 1 band is indeterminate, that doesn't count. That's not a positive result because you don't have 2 positive bands. With Vibrant, if the bands they're looking for to produce a positive result are in that 11 to 20 moderate range, that counts towards the positive result. So what I'm seeing is people coming back with a lot on that sort of first summary page, but that doesn't tell us if it's actually a positive result or not. It just says that this particular strain has some maybe tiny elevation that may be IgG, that may reflect infection, or it may reflect a previous exposure. But my issue with it is that, in my view, to get a positive result, you should have all the individual factors be positive. Right? So if there's a positive and an indeterminate and whatever, that should be an indeterminate result. Now, I understand the dilemma here. I understand that in Lyme testing, typically Lyme tests lack sensitivity, and there's more false negatives than false positives. And so, you know, good for Vibrant in some ways for being like sensitive. However, I do think we need to be discerning in what we're considering a positive result. Also, some of the bands that Vibrant counts on the Western blot, this is the Borrelia burgdorferi Western blot, some of the bands that will count towards a positive result for them are not bands that IGeneX recognizes as relevant. So they're sort of random bands that IGeneX wouldn't even consider even if they were positive. So there's just some discrepancies there. And I didn't love this. And I know, you know, Vibrant's not going to like me for saying this, but this is just the truth. My rep was in one day trying to talk me into, you know, ordering the Vibrant Lyme panel. And I said, listen, here's my concerns. I feel like they're showing everyone positive, because even if there's a little indeterminate or whatever on one single strain of one pathogen, there it is on the positive findings page. And the response was, well, we want everyone to have the opportunity to get diagnosed with Lyme. And I was like, I don't like that. I don't like that. Because yeah, too many people have been undiagnosed, and that's hurt them for many years. So I understand their desire to be sensitive, but we don't want to just have everyone show up as positive for Lyme, do we? I mean, to me, that's not good science either, and that's not good medicine either. So that's where I stand. I'm still Team IGeneX. I really respect that IGeneX, and I have zero affiliation with IGeneX, to be clear. I do respect that they have taken their testing from like the Western blot for Borrelia to the immunoblot for Borrelia, which is like a slightly more sophisticated version of the Western blot. Then they did the immunoblot for tick-borne relapsing fever. And then they developed it for Bartonella. And I was like, oh, we just need it for Babesia. We just really need it for Babesia. And then ta-da, there it was for Babesia. So now, and they're really the things I care about, the 3 Bs, right? Borrelia, Babesia, Bartonella. They're the 3. And, you know, tick-borne relapsing fever is still, it's still a B. It's still borreliosis. It's just not Borrelia burgdorferi. It's just different strains of Borrelia, which for the most part get treated the same way as Borrelia burgdorferi. So having the immunoblot for those 4 things, or the 3 Bs, including tick-borne relapsing fever, I think is awesome. I think it's more sensitive testing now, and they are always developing that. I'm curious to see what their culture testing is going to pan out like. It's so new. I haven't even ordered one yet. So curious to see how that progresses. But that's my complaint with Vibrant. And if you hear any of our webinars on SOT, because we do SOT at my practice, you'll hear us say, oh yeah, we order Vibrant for SOT, because for SOT, you have to have a positive test result for that particular strain in the previous 6 months. And RGCC, the lab that creates the SOT, they accept Vibrant's, yeah, you have an 11, it's good enough for us. So it's good. That works in our favor, right? So sometimes we use that to help, and they do test for a lot of different strains. So in the context of SOT therapy, and if you're like, what's SOT therapy? Go to YouTube and just put in my name and SOT therapy. We've done a couple of webinars on it. That will pop up, but RGCC does take Vibrance testing, and they will take their moderate or indeterminate as a positive result, and they will make the SOT for it. So that can be helpful for our patients, and we utilize that when we need to. So that's it. That's all I got. So obviously, I mean, there's so much at ILADS. There's different tracks. I went to like the new treatments track and the Babesia-Bartonella track. There was a whole PANS track that would have been amazing. There was a naturopathic track, which, you know, ILADS has come a long way to be having a whole naturopathic track. So that was awesome. But since I'm a naturopathic doctor, I was really interested in like trying to learn more about the sort of updates on the medication side of things. So I hope this was helpful. I will, yeah, I'll get the notes to you. I promise I'll get the notes to you. Give me a couple of days, because I'm a little limited on the tech. But thank you all for joining, and all the very best on your journey. And yeah, I'll see you again soon. Oh, one other thing. I'm going to start doing a monthly webinar. I kind of enjoy doing webinars. I enjoy teaching and educating and helping and serving you, my beautiful Lyme tribe. So stay tuned. It'll either be general Q&A. I might have some guest people or topics. This is my way of wanting to share more without committing myself to a podcast. So watch this space. If you're on my list, you will get those notifications, or just follow on social media. All right, everyone, thanks for joining, and I will see you again really soon.